and myself, Uli Jorde, have done this now a couple of times during COVID. And we were honestly attempting to leave COVID behind. But then, of course, very recently, there is a new development with pediatric COVID or Kawasaki disease. And we talked about it among the transplant team last night, not last week, with pediatric and adult. We always have meetings once a week. And then we felt together that this was something that would have great interest. So I'm very happy to introduce Nadine Choueiterim. You're going to correct me, was that okay? Yeah, who is an associate professor in pediatrics and who is the director of pediatric imaging and the Kawasaki disease program, which I didn't know existed. But of course, I understand now how extremely important this program is very seriously. So Nadine, without further ado, take it away. Thank you for making time. And Daphne Sue, also the chief of pediatrics. Thanks.
Hi, thank you, Uli, for inviting me. So I'll be talking today about the pediatric multi-organ inflammation syndrome that has been temporarily associated with COVID-19 and first described in the UK. So I will start by going over the case definition of the syndrome. How does it compare and differ from Kawasaki disease? And in order to do that, I'd like to discuss Kawasaki disease and introduce you to it. And then I will describe the UK and the US experience on this particular syndrome, as well as our experience here at CHAM. So as you all know, on April 27, 2020, the NHS pulled up an alert showing that there's a small rise in the number of cases of critically ill children presenting with an unusual clinical picture. Many of these children had tested for COVID-19 or SARS-CoV-2, but some have not. And they said that the cases have in common overlapping features of toxic shock syndrome and atypical Kawasaki disease, but the blood parameters were consistent with a severe COVID-19 infection in children. Most of the children presented with abdominal pain and GI symptoms, as well as cardiac inflammation. And the first case that was described was 1 month after the COVID peak in adults. So the Royal College of Pediatrics in the UK came up with a case definition based on symptoms, inflammation, and multi-organ dysfunction. And they said that a child who presents with persistent fever, inflammation, with neutrophilia, elevated CRP, and lymphopenia, and evidence of single or multi-organ dysfunction such as shock, cardiac, respiratory, renal, GI, or neurologic disorder fit into that syndrome. This may include children meeting full or partial criteria for Kawasaki disease. Excluded are children with a bacterial infection with Staphylococcus or Streptococcus shock syndrome and infections associated with myocarditis, such as enterovirus. So why do we compare it to Kawasaki disease, and why is it important to recognize Kawasaki disease? So Kawasaki disease is the most common cause of acquired heart disease in children between the ages of 6 months to 6 years in the United States. And even though it is the most common cause, it's rare. Its incidence is 25 in 100,000. It's an acute self-limited vasculitis of unknown etiology, and when untreated, coronary artery aneurysms occur in up to 25% of children, and when treated, that goes down to 5%. It may lead to myocardial ischemia, secondary to stenosis, post-aneurysm, after the aneurysm, sudden death, or ischemic heart disease. Also, it can lead to the other mechanism of ischemia would be clots forming within those aneurysms. So Kawasaki disease also is diagnosed based on a Japanese case definition. There's no specific test for it, and we use classic clinical criteria. So these are children who present with fever that lasts more than 5 days, and with the presence of at least 4 of the 5 principal features that I will show you, as well as excluding other diseases with similar findings, which is kind of what we're dealing with right now with the pediatric syndrome. So these are the findings in Kawasaki disease. first, as you see in the image A, you see that they have bilateral, both eyes, limbic-sparing conjunctivitis, and that separates it from other viral infections that cause watery conjunctivitis, usually in one eye, or conjunctivitis with discharge, which is often a viral etiology. We see swelling of the hands and feet, as well as rash over the hands and feet, and we can have a generalized body rash. The lips and the tongue are often red and cracked. And they can also have, not seen in this picture, a cervical lymph node, usually more than 1.5 centimeters. So if you have 4 of 5 of these clinical criteria I described, then you can diagnose Kawasaki disease. And often what you see with that disease is you see you see an increased white count with a left shift. You see thrombocytosis usually after 7 days of fever. High ESR, high CRP, anemia, increased lipids and triglycerides, hypoalbuminemia, hyponatremia, sterile pyuria. You see increase in ALT and GGT, and you can even have CSF pleocytosis and increased white cells in the synovial fluid. So you can see how the labs overlap with the pediatric syndrome we're seeing right now. Unfortunately, not all children with Kawasaki disease present the classic, in the classic way where we see all or 4 of these 5 features. So the AHA came up with an algorithm for incomplete or atypical Kawasaki disease. So these are children who present with a fever of more than 5 days and have 2 or 3 of the compatible clinical criteria. So instead of having 4 or 5, they have 2 or 3. Or any infant with fever for more than 7 days without other explanation. So if we encounter this scenario, then we are asked to proceed and assess the inflammatory markers, the CRP and the ESR. And if they are elevated, then we proceed down the left side of that, the right side of that pathway, and we look at the lab findings. And if we can have 3 of 6 of these lab findings, whether it's anemia, thrombocytosis, hypoalbuminemia, elevated ALT, increased white count, or sterile pyuria, then we can go ahead and treat, and I will discuss treatment. Or if we can see what we call a positive echocardiogram. And by a positive echocardiogram, we mean that the coronary arteries are dilated, with a dimension that is 2.5, more than 2.5 standard deviations from the mean. We call that a Z-score, and that's how we assess coronary artery size in children. Or if the echocardiogram shows 3 of the following: LV dysfunction, mitral regurgitation, pericardial effusion, or a coronary artery Z-score between 2 to 2.5. And the reason we choose the cutoff of Z-score more than 2.5 or a standard deviation more than 2.5 is because with febrile illnesses, we have seen children can get dilated coronaries between 2 to 2.5 standard deviation. So we don't want to overtreat. That's why the KD community has chosen the Z-score of more than 2.5. So the treatment of Kawasaki is IVIG single infusion, 2 grams per kilo, along with high-dose aspirin for until the patient is afebrile for 48 hours. And after that, we switch to a lower dose of aspirin for its antiplatelet effect, and until there's no evidence of coronary changes at 6 to 8 weeks. And literature has shown that it's best to give this IVIG within the first 10 days of the fever. There's no benefit to giving it on day 6 versus day 7, as long as it's within the first 10 days of the fever, because that has shown to decrease the risk of coronary artery aneurysms. So this is an echocardiogram just to show you that in children we can see the coronary arteries. This here is your aorta in short axis. This is a parasternal short. You can see a dilated left main. You can see what we call a fusiform spindle-shaped aneurysm in the left anterior descending and in the circ as well. So we're able to see those, and that's how we diagnose those aneurysms on echo in children. So going back to the pediatric multi-organ inflammatory syndrome. So I'm going to describe the clinical presentation of that syndrome in the UK and in the US, and they're very compatible. And I will also compare it and contrast it to Kawasaki. So in the UK, they reported 38 cases with a median age of 11 years with a slight male predominance, close to 60%. It was mostly in Black, African, and Caribbean, 46%. 12 of those patients were PCR positive and 24 were PCR negative, with 11 of those PCR negative being IgG positive. 75% of them presented in shock, and 51 with myocardial involvement, which included decreased left ventricular function and valvulitis, mainly mitral regurgitation. And 16% had coronary artery abnormalities, such as coronary artery dilations or aneurysms. 54% presented with variable rashes, and less than a third presented with some of the symptoms that we see with Kawasaki disease, such as conjunctivitis, mucous membrane involvement, swelling of the hands and feet, or lymphadenopathy. And what's interesting is that more than 50% presented with abdominal pain with and without diarrhea. And we have seen this here at CHAM, where they present with an acute abdominal pain picture, and at times it's thought to be appendicitis. And one patient actually in the UK was going for a laparotomy, but they found nothing, and it was all enteritis secondary to this syndrome. 38% have acute kidney injury, but the need for renal replacement therapy and dialysis is rare. 20% have some sort of CNS involvement, mostly headaches, and unlike adults, only 30% of them had respiratory symptoms. 50% were treated with steroids, 60% with IVIG, 8% with anakinra and IL-1 inhibitor, and 38% had supportive care in the ICU with inotropes, intubation if needed, or mechanical ventilation. And the presenters who presented that data over a Zoom webinar of the PICU collaborative did not go over their treatment algorithm or how they decided who got what. Moving on to the United States, 17 cases have been described, and one of the centers was here in New York, as well as a center in Boston. So they looked at their ICU admissions for shock or cardiovascular dysfunction. 94% required vasopressors, 2 were on ECMO. The majority were more than 6-year-old, also male predominance. They all obviously presented with fever. 88% had some sort of GI manifestation. 88% had shock. 41% had respiratory manifestation, with 4 requiring intubation. 40% presented with one of the signs seen in Kawasaki disease. 88% presented with cardiovascular dysfunction, primarily mild to moderate. So 12 of 17 had mild to moderate dysfunction. They all had elevated CRP, ferritin, D-dimer, and interleukin-6. So in the US, 94% got steroids, 18% got IVIG, 24% got anakinra, and 1% got tocilizumab. And again, they didn't go over how they decided how they decided on their treatment algorithm. So the lab abnormalities that we have seen and that others have seen is predominantly neutrophilia, lymphopenia, anemia, increased or decreased platelets, elevated inflammatory markers, D-dimer, pro-BNP, troponin, procalcitonin, and IL-6. And it looks a lot like the cytokine storm that has been described in adults. Very similar laboratory data. So how does typical KD compare to what we were calling COVID KD, or to the vasculitis that we're seeing with SARS-CoV-2 presumed infection or infection? So usually the COVID KD are older in age. They're above 6 years of age. They have much higher white counts, but they're more lymphopenic, more anemic, more thrombocytopenic, and hypoalbuminemic. They have much higher pro-BMPs, much higher D-dimers, ferritin, and CRP. So what is the pathogenesis? What do we think? How do we think this is happening? Why is this happening? So there are two mechanisms that have been postulated. That is this triggered activation of the innate immune system, leading to release of pro-inflammatory cytokines, excessive activation of the macrophages, and uncontrolled host inflammatory response, and that would be T-cell mediated, or whether it's antibody-dependent enhancement with early neutralizing antibodies promoting cellular uptake of virus particles bound in immune complexes, though through their binding to the Fc gamma receptors, and that would be an immune complex mediated response. So one thing to look at is that the peak of this syndrome was, as I said, 1 month behind the COVID-19 peak, both in the UK and the US, and that's going to help us understand the cases that I will describe at CHAM. And again, many children were found to be COVID PCR negative or SARS-CoV-2 negative, PCR negative, but antibody positive. So could this be a delayed antibody-mediated inflammatory response? We don't know. So at CHAM, from March 1st until last night, we've had 32 potential cases with a mean age of 8.9 years, anywhere from 2 months to 20 years. We've seen 56% male, 31% Black, and 45% Hispanic. So, sorry, it should be 32 cases. Essentially, this is how these cases are distributed and how they come, where they overlap. So we had, during the COVID peak, we had 11 cases, 9 presented with ARDS, like pictures similar to adults. Some are still in the unit, at least 4. 2 presented with multi-organ dysfunction, and they have died. And then 22 presented a month later so a month after the COVID peak with signs or symptoms very similar to the pediatric multi-organ inflammatory syndrome that's been described in the UK. And they have presented in 3 different presentations, either shock with or without myocardial injury, Kawasaki disease-like illness, or acute myocardial injury with myocardial injury with a troponin leak and dysfunction. So among those who presented with the shock and multi-organ dysfunction, both were PCR positive. They presented during the COVID peak. They had comorbid conditions like hypertension and obesity, and one of them had neurologic disorder as well. They were both in the ICU. They were both intubated. One had a troponin leak without LV dysfunction, and one had LV dysfunction that normalized months later, but required CRRT and passed away. So among the cases that fit the criteria of the PMIS, we had 23 cases. And you can see that the cases overlap in their presentation. So we had 12 Kawasaki's, complete or incomplete, 14 acute myocardial injury, and 9 shock. But you can see that 3 presented with all of those presentations. They had shock, they had LV dysfunction, they were on inotropic support, and then they developed a conjunctivitis or a rash, a conjunctivitis and a rash, or had coronary artery dilation, and so were treated for Kawasaki disease as well. So among the 4 who had shock with myocardial dysfunction, so only had shock with myocardial dysfunction, the ejection fraction was anywhere between 35 to 45%, and they were anywhere from 2 months to 13 years of age. 3 were PCR positive, 2 were intubated on inotropes, and 1 was not intubated and was not on inotrope. In all those 3 patients, the function either normalized or improved. And 2 of those patients also had atypical Kawasaki disease features. One had a transient mild coronary artery dilation that resolved within 72 hours. One patient was PCR negative with no antibodies done, was treated for and diagnosed with atypical Kawasaki disease because of conjunctivitis and a rash with a fever lasting more than 5 days, had no coronary artery dilation, was not intubated, and not on any inotropes. So the overall outcomes is 4 are alive, 1 is discharged, 3 are in the PICU. They've all received, they've all received steroids and remdesivir. 3 have received IVIG based on a diagnosis of atypical Kawasaki disease, and 2 have received anakinra for the cytokine storm-like picture. So 8 had acute myocardial injury. They were aged 5 to 12 years. 4 were PCR positive. 1 required inotropes for 48 hours. Again, the ejection fraction in these patients was 35 to 45%, similar to the shock patients. Function either improved or normalized. 4 patients were, 4 of these, so the 4 who were PCR positive were also all 4 of them in the PICU, but only 1 of them was on inotropes and required steroids or given steroids. 4 were PCR negative, 3 were IgG positive, and 1 did not have antibodies done. Also, these 4 were in the PICU, but 1 required, or 1 was given steroids, and 1 was not on inotrope, and all 4 of them were not on any inotropes. Required some fluid resuscitation. The reason they were in the PICU, the majority of them, the majority of those who were in the PICU were there for hypoxia and the need for high flow nasal cannula, and not for inotropic support. They stayed in the PICU 2 to 10 days. The mean was usually 3 days. 8 are alive, they're discharged, and 7 of those patients have normal function that has normalized 5 days to 2 weeks later, and 1 has improved function. The ejection fraction went from 35% to 48%. So finally, our Kawasaki disease patients, we had 12 of those, 5 months to 18 years of age. 3 had a positive PCR. 1 presented with atypical Kawasaki disease with shock and required inotropes, had transient coronary artery dilation that resolved. 2 were atypical Kawasaki's with shock and dysfunction, and 1 was intubated, again, with transient coronary artery dilation. Among those who had PCR negative, so 9 of them had PCR negative, we did not have, their antibodies were negative as well. 1 was diagnosed with classic Kawasaki disease, had all the features of Kawasaki disease, and had no coronary artery dilation. 1 had atypical Kawasaki disease with shock and dysfunction, but no coronary artery dilation, and 8 were atypical Kawasaki's. They were all on the floor, not in the ICU. 2 had coronary artery dilations that have, 1 of them has improved, and the other one was the other one we haven't had a chance to check because it was a recent admission. So overall, 12 are alive, 3 are in the PICU, 8 discharged. No IVIG resistance, which is important because the way we document successful treatment, or the way we know that a child has responded to IVIG, is we want to make sure that there's no persistence or recurrence of the fever 36 hours after the IVIG infusion is done, because those children are at an even higher risk of developing coronary artery aneurysm. So we call that IVIG resistance if they become febrile again. And so we did not see IVIG resistance. And we had 3 of the coronary artery dilations that have resolved within 2 days to 2 weeks. So these are the laboratory abnormalities that we've seen in our patients. We've seen CRPs more than 20s. We've seen lymphopenia, and we've seen normal to low platelets, which is interesting because in Kawasaki disease, we're supposed to see high platelet counts, only 3 patients had a platelet count more than 450. We've seen high pro-BNPs in the thousands, and in our shock patients, more than 15,000. Elevated troponins, elevated D-dimers, in our shock patients, even more than 15, elevated ferritin, LDH, and also elevated procalcitonin, and increased interleukin-6. So similar to the UK data and the prior US data. So what are we doing at CHAM? So we're working on a clinical pathway similar to what you guys have done on the adult side, to help pediatricians and ER physicians recognize this syndrome, decide who needs to be admitted and who does not need to be admitted and can be watched, understand which labs need to be ordered for screening, and then based on the presentation, decide on whether the child goes to the PICU, receives supportive care, or is treated treated as a Kawasaki disease patient, or is treated as a myocarditis patient, also supportively. And we have put on the side the definition of Kawasaki disease to help physicians while they're triaging the patient to go over that list and see if the child satisfies the criteria of typical or atypical, because we're only giving IVIG to those who satisfy the criteria of classic or atypical Kawasaki disease. And then what happens after they leave the hospital? We're working on creating a pediatric or a CHAM clinic for these patients. It's a multidisciplinary collaboration with infectious disease, rheumatology, hematology. We've decided it's going to be weekly. We're going to see those patients a week after discharge, 4 weeks, 6 months, and a year. We're going to decide on which subspecialty sees them and what tests they get based on their initial presentation and their clinical course. And that would also dictate what tests we order and what lab we order. So, for example, if they've had a myocarditis-like picture, they would get at 6 months a cardiac MR, a Holter, and exercise stress test. If they had Kawasaki disease and they had coronary artery aneurysms, then we would consider a CT or a CAS by 6 to 12 months to assess for coronary artery stenosis that can develop after the aneurysm as the artery is remodeling. And that's all I have for you. Thank you.
Okay, that was terrific, Nadine. We can have questions in the chat here. Don't know if Daphne wants to comment, but for me, just to clarify this again, we talked about this last week. How much Kawasaki disease do you usually see, let's say per month? Is it seasonal? And then it seems to me that in this cohort, you showed both Kawasaki disease with or atypical with negative antibody and negative swab, so they're really kind of Kawasaki spectrum. Mm-hmm. And then I say 75% of the cases, if I counted correctly, something like that, actually had either an antibody or a swab positive. If you just can comment on what do you usually see, how is this different? Is this an avalanche of Kawasaki spectrum disease that you're seeing?
I think, so yes, so Kawasaki disease, as I said, is rare. Patients do come in cluster. People have described a seasonal variation seen mostly in the winter and spring. Yet, for example, over a year, we might see 20 to 30 patients at CHAM. So this number of what we're calling Kawasaki disease is definitely higher. Yet I'm not sure we are truly dealing with the Kawasaki disease that we were dealing with before COVID-19. I think this is a vasculitis that is triggered, or a vasculitis that is somewhat associated with the pandemic that looks a lot like Kawasaki disease, and so far, in some cases, behave like Kawasaki disease. However, what we have seen, the fact that the coronary arteries are dilated, but then within 72 hours go back to normal, that's not typical of Kawasaki disease. Usually Kawasaki disease, the coronaries can dilate up to 2 weeks. That's why we follow them very closely in the first 6 weeks. The other thing is the labs. So with Kawasaki disease, you see thrombocytosis. In some of these patients, we see thrombocytopenia. And with Kawasaki, we don't see lymphopenia. We don't see increased D-dimer or increased ferritin. And some people have described it or that it looks like Kawasaki shock syndrome. But Kawasaki shock is even more, it's rarer than Kawasaki itself. It's 5% of the Kawasaki cases. So, and these patients also respond to IVIG, meaning when they get IVIG within 72 hours, their function recovers. And in our patient population, we are not seeing that. We're giving the IVIG thinking that it's a vasculitis, and we're trying to prevent coronary artery aneurysms in the future if it looks like Kawasaki disease, but we're not giving it to treat the cytokine storm or to treat the shock.
Okay, there's some really good questions here. One is from Mark Menegas. He says, "Great talk. What other immunological markers are being looked at?" And just answer this briefly. There are more questions. I just give you the next one already, which is an excellent question. Why did we not see the signal in the China and Italian experience? Is it related to different viral strains? So you can speculate on that.
So for the first question, rheumatology is handling that, but usually we get IL-1s and IL-6 when we look at those interleukins. And then if rheumatology feels that they need to order more, like IL-10 and other interleukins, they do. In terms of the virus, we think that the virus that we are getting is a different mutation, is a mutated virus and is different than the virus that came from Wuhan. Because we are seeing way more cases, we are seeing similar cases to Europe with a similar presentation. And the West Coast is seeing some of those cases, but not as much, not with the same quantity as we are seeing here on the East Coast. So we think the West Coast got the Wuhan virus and we got the European virus that has mutated.
Okay. Okay, Daphne, do you have, or Azim?
Yeah, no, I think, that's a great point. And it's been a concern for all of us because initially when we saw the Chinese data, and even, speaking to our colleagues in Italy, we thought this was predominantly adults, COVID, and we're not going to see much in our kids. So seeing this is concerning, but I think your theory about mutation makes sense. There is one more question before we ask Daphne to make some comments, again from Mark. Do we have any sort of histological tissue in any of these kids that has been looked at, whether that's a biopsy, and a myocardial biopsy or other biopsies, to understand what's going on?
No, we have not done that. And I think Daphne can comment more on why we haven't done it. But we haven't done it, no.
Okay. And maybe Daphne, I'll hand it over to you if you want to make any final comments, and we'll see if there are any other questions that come from the chat.
Yeah, just a couple of brief comments. It was great talk, Nadine. The question about the European, the Bergamo and Barcelona groups have seen this disease as well as England. So it does seem like it's related to the European form of the virus. And thinking about testing, certainly biopsying kids is even a little more risky than biopsying adults, especially those kids. So we really have not wanted to do that. And even MRIing them, it's a big deal to try to get them into a scanner. So we don't really have any more advanced imaging for inflammation. I think the biggest challenge to me is that IVIG. We always use IVIG to KD. KD is proven to be, prevents coronary aneurysms, Kawasaki disease. The question is, what does it do in COVID? It's a very big volume. A bolus of volume. It's like 40 cc's per kilogram. A normal volume bolus in a child would be 10. So it's going to, as we know in COVID, we're trying to limit volume in the patients. It also has prothrombotic effects. It can cause trolley. It can cause renal dysfunction. So we're having this sort of challenge because now we're giving it to children who come in with COVID, obviously having a cytokine storm pro-inflammatory picture, and is IVIG the right thing to do? And I think that's what we're thinking about. We're thinking, should we even try to do a little pilot study about it? Because I think there are negative effects. I've seen a couple of kids who gave the IVIG to, they had to get intubated, which, so it's not without its risks. And how do we think about it in the cases that are not typical classic type KD? So.
Yeah, that's great. Thank you, Nadine. Thank you, Daphne, for those final comments. And I think it's great to, understand our local experience and what we've learned at Monty from this. I think for a lot of us, and physicians and non-physicians alike, when we've seen this has become sort of a highlight in the newspapers and the lay press recently. So it's been really useful to bring it to light. I see maybe one last question before we move on. From our data or the other published data, are there any demographic or other features that seem to predispose children to the syndrome?
So most of these children, as I said, were previously healthy. A lot of the data shows